Philadelphia International Medicine, PIM, provides international patients and physicians with access to an unmatched network of world-renowned doctors, surgeons, and hospitals that deliver personalized medical, surgical, and rehabilitative care ranked among the best in the world. Since 1999, Philadelphia International Medicine has helped patients and physicians from around the globe eliminate the guesswork, planning, and anxiety of finding and connecting with doctors and hospitals ranked among the best in the world. With 8 hospitals, 2 medical schools, 2 cancer centers, and hundreds of top doctors, only PIM can bring you into its medical family with one easy phone call or email. Thanks for joining our presentation. Philadelphia International Medicine's Global Education Media Program is a monthly digital platform that invites physicians from around the world to exchange knowledge and innovative uses of medical technology, review the latest advancements in research and clinical care, and share best practices in case reviews. To contact our presenter, refer a patient, or more information, email physicians@philadelphiamedicine.com. Follow PIM's YouTube channel for more educational videos.
Well, thank you very much, and thank you for joining us here today. I'm Chris Formal from Magee Rehabilitation Hospital here in Philadelphia. We're part of the Regional Spinal Cord Injury Center of the Delaware Valley, along with several other institutions, including Thomas Jefferson University Hospital. Feel free to contact me, cformal@mageerehab.org. Today we wanted to talk about a couple specialized topics of ways that we approach patients here at Magee. The 7 areas I thought we'd talk about were some aspects of ventilation management. It's going to go over the terrible problem of pressure ulceration. We'll review a couple spasticity treatment options. I'll mention some upper limb reconstruction concepts. We'll go over some of the newer active therapy modalities for gait training. Look at some of the functional electrical stimulation systems, and finish up with just a mention of some potential stem cell therapies in a project that we're currently involved in. Upon arrival at Magee Rehabilitation, we often have patients who have healthy lungs, but absolutely no ability to ventilate due to a high spinal injury. In addition to no vital capacity, they're unable to cough because of paralysis of intercostals and abdominal muscles. They can't speak and they can't swallow. And actually, those last 2, inability to speak and swallow, may be the most important to the patient when the patient first arrives here. Secretions are almost always problematic because the patient has lack of sympathetic input to the lungs due to spinal shock. The parasympathetic input from the vagus is still there. The combination of a lack of cough and increased secretions, that combination can lead to atelectasis. Of course, the next step from atelectasis is pneumonia. So our goal early on is to prevent atelectasis, and probably apart from medicines, the most important aspect here is aggressive physical clearance of the secretions with suctioning, use of an insufflation exsufflation device, and various types of chest physical therapy. We also set the ventilators with relatively high tidal volumes. Our thought is that the patients usually have healthy lungs, and we're probably not going to hurt those lungs with the high tidal volumes, but we may be able to help prevent atelectasis. So often patients here will be ventilated with volumes greater than 10 milliliters per kilogram. And physical measures are paramount, and suctioning, of course, is the mainstay. We also use the insufflation exsufflation device. also called the Coughalator, where the treating therapist or nurse can apply a positive pressure to the lungs, 30 centimeters of water pressure, and then can open the system, but not just to atmospheric pressure, but to a negative pressure. So it quickly goes from positive 30 to negative 30, and that gradient, that differential, brings the secretions out of the lung. Unlike suctioning, which may preferentially clear the right lung, the Coughalator may have beneficial effects for both lungs. Physical therapy, positioning, pounding on the chest, and also mechanical elaboration of that. This is a device called the chest vest, wraps around the patient, provides vibratory energy to the lungs to help mobilize the secretions and help to clear them. We mentioned that inability to talk and inability to swallow are often what's most important to the patient when the patient first arrives. So speech therapy aggressively works with the patient. We use minimal leak technique, trying to deflate the cuff a little bit so that air will go up through the vocal cords, the person can talk. Conversion to a cuffless trach as soon as possible. Can even use a cuffless trach while we're using a ventilator. When the person weans, we start working with talking valves, the passing ear valve, and capping. Our patients ideally are up and out of bed some of the day. Most of the day we want them out of the room. So the ventilators that we usually use are the smaller notebook ventilators. They're fairly sophisticated, but they're still a lot less cumbersome than the units that one might see in an acute care hospital. There's alternatives to a positive pressure ventilator. Though a positive pressure ventilator usually works very well, alternatives include phrenic nerve pacing and the use of a diaphragm pacing system, sometimes in conjunction with nerve grafts. This, of course, is the basic anatomy. Bear with me, but this is the way I think of it. We have an upper motor neuron, and we have the lower motor neuron, the phrenic nerve that drives the diaphragm. Of course, this is our problem. It's a high cervical spinal cord injury that divides the ventilatory centers, the respiratory centers from the phrenic nerve, so that there's bilateral diaphragmatic paralysis. That phrenic nerve is healthy, and a healthy nerve can be electrically stimulated, and that's the idea behind phrenic nerve pacing, where stimulating electrodes are applied by surgery. You can see an antenna over there on the patient's right. Wires connect that with cuffs that go around the phrenic nerve. It's an implanted system, and nothing mechanical passes through the skin, but energy does pass through the skin in the form of radio frequency waves that come in through an external antenna to the receiver that you see there, and from that to the phrenic nerve. That surgery can be challenging because it's up in the neck, and the diaphragm, if it hasn't been used for a period of time, is probably atrophied, and it must be conditioned over a period of time. With proper conditioning, the goal there would be to use the phrenic nerve pacing system 24/7. The diaphragm itself can also be directly paced. The basic science here is that muscle with intact lower motor neuron can easily be stimulated with electricity to contract. So here one can have a patient with a high cervical spinal cord injury. Of course, no messages are getting to the phrenic nerve, but the phrenic nerve survives. It's healthy. It still innervates the diaphragm. The situation there is that electricity can be applied directly to the diaphragm, bypassing the phrenic nerve and allowing the patient to have ventilation. Now here the system is percutaneous. The power comes from an external power generator that's connected to the diaphragm stimulating wires through percutaneous connection. So here wires do go through the skin, so in that way it might not be as elegant as a phrenic nerve pacing system. It can be used as a weaning aid or a 24/7 destination. The surgery is a little bit easier than that for a phrenic nerve pacing system, and it can be used relatively early in the course. They can be placed while a patient's only been injured a week. Here again, one must condition the diaphragm because it can atrophy fairly quickly when it's not used. Surprisingly, to me, there are few skin problems. I've never seen one, and I've never seen infection related to it. The rate can be set externally through the clinical station. That can be varied for if the patient's exercising or at rest, can be adjusted to provide the patient the optimal settings for vocalization. So this is the situation that we've considered a lesion of the upper spinal cord with intact phrenic nerve. But often the injury is different. The person's tetraplegic, but the levels from C3 to C5 have been destroyed, and that phrenic nerve is not functioning. There's no phrenic nerve there to pace, and the diaphragms are denervated, and thus they will not respond well to electrical stimulation. The management there is to apply a nerve graft directly to the diaphragm so that the diaphragm then is innervated, and then the diaphragm can become stimulated. The nerve graft could be harvested from anywhere below the lesion. Intercostal nerves or nerves to the abdominal muscles could be utilized. We kind of schematically put in a picture of the nerve graft there. The phrenic nerves, they may be gone, but the nerve graft provides innervation to the diaphragm. Now, why should one use phrenic nerve pacing or a diaphragmatic pacing system as an alternative to a positive pressure ventilator? Well, they're typically quieter. The patient can sleep better. There's less hardware. There's more natural pressure relationships within the lung. Might allow decannulation. And patients tell us that they sometimes regain a sense of smell or taste that's lost with the use of mechanical positive pressure ventilation. I want to go on here to our second topic, that of pressure ulcer management, which is a wicked problem. And managing the pressure ulcer sometimes takes longer than managing the spinal cord injury itself. And a person who might have a spinal cord injury and be out living her or his life might have the course controlled by the pressure ulcer in some ways more than by the spinal cord injury. So that's the terrible problem that we're often presented with when a patient arrives here to Magee. And all we're seeing here is what we've known for a long time, the interaction between high pressures over here and time over which the pressures are applied. X's are bad, so if there's too much pressure for too much time, well, we know the result of that is a pressure ulcer. It's not only pressure, and we've also known for a similarly long time that the problem of shear, often with bed positioning, where the skeleton might move in one direction, where the skin's held fast so that the skeleton moves one way and the skin effectively moves another way. distorts the blood vessels in between, and the tissue dies. We work hard with specialized, sophisticated mattresses, air cell surfaces, low air loss mattresses that are always providing some airflow through the mattress to keep the skin dry, and alternating pressure mattresses to take advantage of that pressure time curve that we saw earlier, so that pressure is kept low some of the time, so that there's never high pressure there for a prolonged period. Use wheelchair seat pressure mapping with technology that can show the clinical team where there are problem areas. A red spot indicates pressure that's too high, pressure that's way over capillary pressure would leave the patient vulnerable to injury. The chairs also can be smart. They can communicate with a cellular telephone shown over here. The cellular phone can communicate through the internet with the rehabilitation team, and can provide information about the patient's weight shifting activity, how often the person weight shifts, how long they weight shift for, what angle they use for weight shifting. So given a problem like that, what do we do? Because that's a daunting problem, and we face it, unfortunately, fairly often. We can't fix that quickly. It may be 8 weeks or more to get a satisfactory resolution. An approach here might be a period of education and aggressive nutritional support, followed by surgical or deep debridement, rather than simply bedside debridement, with bone culture and bone biopsy. That'll often reveal bacteria, osteomyelitis, that then can be treated for a week or two, followed by flap repair. Thus, this is called a stage procedure or a staged repair. The flap repair requires a period of bed rest. One can have a heart transplanted or a liver transplanted and be home in a week, but after flap repair of a pressure ulcer, one's at bed rest, ideally here at Magee for a period of 3, 4, 6 weeks, until we and the operating surgeon are confident of the strength of the healing. After that, there's a gradual period extending over at least 2 weeks of mobilization, increased time out of bed, and equipment prescription. When things work out, which is 75, 80% of the time, we get something like that, and due to the flap nature of the repair, we get a repair that with proper equipment, proper behavior by the patient will give lifetime of service. Moving on, we wanted to mention 2 of the spasticity options that we consider when our more basic interventions, like education, stretching, systemic medications don't provide an adequate result. Here, botulinum toxin is an option for hypertonicity that affects a limited number of joints. Intrathecal therapy is available for more widespread spasticity. So here, with equinus posturing, a typical issue for a patient, the procedure would be to identify the responsible muscles, the calf muscles, tibialis anterior, tibialis posterior. Then needle them, confirm the placement one way or another with, electrical pickups through the needle can confirm that the placement is in muscle. Stimulation through the needle can then confirm what muscle is being stimulated, and/or placement can be confirmed with ultrasound imaging of the muscle and the needle. After that, the botulinum toxin can be injected, Person gets a good result after 5 to 7 days. That may be it, or process may have to be repeated in 4 to 6 months. That's a device there that attaches to the electrode needle that is also used for injection of the botulinum toxin. For more widespread spasticity, intrathecal application of baclofen, of course, is almost always effective, greater than 90% of the time, relatively low dose, without cerebral effect, and it's adjustable percutaneously. Most of the effect is seen in lower extremities, lesser effect in the upper extremities due to the placement of the intrathecal catheter. This is just a picture of the pump, of course, which is implanted. One can communicate with that here through the external pack here. Printouts of reports are here through the printer. Refills are done percutaneously with this kit. Process here is identifying a reliable patient. Patient has to return for follow-up and refilling of the pump, because there's no limit to how bad things can go if the patient doesn't get the pump refilled. And of course, no limit to how bad would be a fatality. There's a temporary trial via lumbar puncture to prove that the therapy will work, and then if that's effective, the pump can be implanted. After that, the dose can be titrated, and the patient comes back for regular adjustment of the dose and refilling of the pump. It's a picture of the pump. That's how it looks on X-ray, with its catheter going through to the intrathecal space, subarachnoid space. We move on now to possibilities for upper limb reconstruction in patients with tetraplegia. They might have redundant muscle for certain movements, but no muscle that's active for other movements. So we could consider, for example, a person with C5 tetraplegia. That person has C5 muscles, so there's powerful elbow flexion, biceps, brachialis. Other muscles, brachioradialis, are working. But muscles innervated below are paralyzed, thus elbow extension is lost. One can imagine what happens if the arm, if the shoulder's abducted over 90 degrees. Of course, the elbow buckles and the hand falls down and hits the person in the face. This lends itself to surgery in which one of the elbow flexor muscles or a part of the deltoid muscle can be reattached, rerouted to the tendon to serve for elbow extension. This requires a motivated patient who's willing to tolerate post-surgical immobilization in which function that they've already worked for is going to be lost. This is how a different procedure might look schematically. We'll think of a person with a C5 injury and a couple muscles that function for elbow flexion, but no muscles down here working for finger flexion. Reconstruction can proceed so that one of those muscles is attached mechanically here to a finger flexor muscle. Or even alternatively, a surgeon could take a nerve that's serving an elbow flexor muscle and reroute that to provide innervation for a finger flexor muscle. We're going to talk now about some of the newer modalities for gait training. And the four that we're going to mention are traditional body weight support training on a treadmill. We'll look at robotic body weight support training. then overland suspended training, and also the use of external skeletal orthoses. Now, common advantages to these are that the patient is upright, perhaps more so than if the patient's using a walker or parallel bars. The hands are free. The arms can swing reciprocally with the lower extremities. There's lots of sensory input received through the lower extremities. If we do this repeatedly, we take advantage of Hess's law. If we repeat it a lot, synapses that fire together will wire together. This is traditional manual body weight support training. This training is very resource intensive. We have 3 or actually 4 therapists working with the patient. It's physically demanding for several of those therapists. They work to provide vigorous sensory input to the patient by pushing, slapping the foot down hard on the treadmill, and also by moving the limbs in a fairly sharp manner so that, the body senses vigorous extension of the hip in the hope that that may trigger some active hip flexion. There's immediate therapist adjustment to performance of the patient. There's the powerful sensory input. Can accommodate lower levels of activity, or even if the treadmill rate is turned up, higher levels of activity, such as running. And we found that it's useful for activities other than gait. So we may do gait training, but it may also help with the patient's trunk control and lead to improved performance of transfer activities. It's expensive in terms of resources. It's physically demanding of those who are treating, and it can be injurious both of the patient and the treating therapists. Robotic can also be used. That's much gentler on the patient, so that an advantage there is that it's very gentle on arthritic joints, so that a person with some sensation of knee pain from arthritis may very much prefer robotic training over traditional body weight support training. It's also gentle on staff. Disadvantages are there's lack of the hands-on information going back to the therapist, and there's difficulty with immediate adjustment. Overland body weight support training provides advantages in that the patient can move from side to side. Also, obstacles can be placed in the patient's way. Even the patient can be placed in front of steps, depending on the arrangement of the suspension system, and can train on stairs. Good and bad points are it's relatively more natural, it's over ground. We use the obstacles. An ambulation aid, such as a cane, could be used more easily than if one's using a treadmill. It's generally useful only for those who are already relatively functional, and there's little direct physical therapist input. External skeletal systems can be used both for practical mobility, in other words, simply to get from point A to point B. They also can be used for training. They involved a battery-operated exoskeleton device that allows standing and a reciprocal gait on level surfaces. There's miniature motors that power the hip and the knee joints. Within reason, it can be adjusted to fit persons of different sizes. Almost always used with an ambulation. It's possible to pick up the skill of using the device in a relatively short period of time. Person can use either a walker or canes or forearm. Here they're shown being used with a suspension device, but person can graduate to using the device without any suspension and without any direct contact from the therapist. Move on now to some aspects of functional electrical stimulation. Of course, with upper motor neuron injury, the paralyzed muscle often can be fairly easily stimulated. That can be used to strengthen the muscle, and that was its earlier use. Can also be used for function and to provide aerobic stress that the patient might otherwise be unable to generate. Here's an example of some functional use. This person has left toe drag. You can see that the toe gets dragged as she walks along. An option there is an externally applied system. Now you can see that left toe is stimulated by an external system. The person has much better clearance of the foot. A relatively inconspicuous device. That's programmed to stimulate every time she takes the foot off the ground. There's no pressure on the heel. Stimulus is applied to the dorsiflexors. Upper extremity systems are also available. And this isn't going to show for us, but that provides extension of the wrist and finger flexion. Multiple channels are available in some of the systems, and these can be used for functional activities involving several joints, such as hand-to-mouth activities. The multiple channels can be applied to muscles of the rehabilitation team's choice. They can be applied over large areas and help with strengthening of muscles such as trunk extensor muscles to help improve the patient's wheelchair posture. Going to move on to mention of some potential stem cell therapies. Of course, stem cell therapies are a subset of investigations that are ongoing to help improve neurological outcome. Magee, Jefferson are involved in both sorts of studies. Stem cell treatments are prominent among those, and they certainly have the attention of patients and the public. There's difficulties in studying therapies to improve neurologic outcome in spinal cord injury. First of all, people with spinal cord injury may improve naturally, and thus it's more difficult to study than a disease process in which improvement does not occur, such as with, for example, cancer. Injuries are not common, so a study must often deal with multiple sites in multiple clinical teams. If the intervention is one that's going to be applied early after injury, the patient may have so much going on that it will be difficult to obtain consent. Now, why would stem cells help for a person with spinal cord injury? Well, obviously our first thought is that they might replace lost nerve cells. They also could provide a myelin sheath to surviving nerve cells that aren't functioning because they've lost their own myelin. The cells might somehow modify the local environment in a beneficial manner. The strategy for stem cells could vary between those who are recently injured and those with a more chronic injury. And similarly, the strategy could be different for someone with a thoracic lesion, where the loss is practically all axonal, and those with a cervical injury, where the loss of the nerve cell bodies is also crucial. Our current study involves oligodendrocyte precursor cells that might have several beneficial effects for a damaged cord. The cells are applied by direct injection into the spinal cord, not around, but into the cord. There's ongoing recruitment for patients. Currently, patients with levels of C5 through C7, Asia Impairment Scale B, with treatment to be applied within 6 weeks of injury. We hope that this and other studies will be successful and work towards improving treatment for patients with long-standing injury. That concludes my presentation from here at Magee in Philadelphia. Thank you very much for joining us today.